GECO session hosted by the Foundation in partnership with Project ECHO of the University of New Mexico. This afternoon's meeting, an extraordinary meeting of GHASSA, the Gastroenterology and Hepatology Association of Sub-Saharan Africa, in partnership with AUDA-NEDPAD, the developmental wing of the AU. My name is Chris Cassanides and I chair the foundation. It's a great pleasure to have you all here. We have over 100 registrations from 19 countries, representatives from various health sectors in the continent, including the AU and WHO. The aim of this meeting is a dialogue really between GHASSA and AU-NEDPAD in an attempt to present aspects of our various subspecialties, our GI hepatology subspecialties that we've been hosting over the last months, in order to select some that perhaps might benefit from an interaction with a governmental organization such as the AU, driving them, for example, from a top-down aspect to achieve a better healthcare for our continent. Thanks to Professor Augrey Mbali from AU-NEDPAD, our senior advisor at the AU, who is my go-to man and who's assisted me in putting this meeting together. And also, I'd like to thank Chinwembe Chamdimba, a principal policy specialist from AUDA-NEDPAD, who I had a chance to meet for the first time this morning, and I'm very excited by this interaction, and I hope that we'll have a lot of success together. The chat is open for questions, so you're welcome to post them. You're also welcome to put on your video and ask questions verbally. So it's a great pleasure then to ask Sanjeeva Arora, dear colleague and good friend, who's the director and founder of Project ECHO, who will say a few words.
As a thank you, Chris, for hosting this meeting, for your leadership and of ECHO in Africa. I just want to start by saying that ECHO stands for Extension for Community Health Outcomes, and our mission is to democratize medical knowledge to get best practice care in underserved areas all over the world. And I want to particularly thank 4 people for pioneering the use of ECHO in Africa. And of course, Chris Cassanides, Wendy Spearman, Geoff Dushenko, Mark Sonderup, all of them who got together and came up with the idea of starting a pan-continental ECHO to improve liver disease care for viral hepatitis across the continent. And it's really so delightful to actually say, I'm so delighted to see the tremendous success you've had. ECHO has also been growing all over the world and has been deployed in a major way in the COVID-19 pandemic. As you can see, in 2019, ECHO had 229,000 learners in about 150 countries. In 2020, that number went up to 1.3 million, and our growth continues in 2021. We now have expanded all over the world. We have hubs in more than 600 countries with, as I said, learners in 179 countries. Africa has been a particular focus area for us. In addition to the liver disease ECHO, which is across the continent, we also have ECHOs in other countries in Africa dealing with HIV and rapid testing and viral load scale up and chemical pathology, lab information systems, quality improvement, data for action, antimicrobial resistance, infection control and prevention, biosafety, global health security, outbreak management for Ebola, surveillance, safe surgery, cancer, and others. Currently, we have about 70 hubs in Africa in all the countries mentioned here. And there are certain countries where, certainly Kenya, Uganda, where we have about more than 20 hubs each. But our hope is that all the African countries will adopt ECHO. There is literally no limit for us to set up ECHO hubs for different disease areas in Africa. And I invite all of you who are from 19 countries to reach out to us, and to reach out to Chris and Wendy Spearman and Mark Sondrup for us to collaborate with you and bring the platform and the training to launch ECHOs. These are the ministries of health in Ivory Coast, in Tanzania, Egypt, Ghana, Uganda, Sudan, Lesotho, Namibia, and Zambia that have already signed collaborative agreements with us. And I don't want to end without thanking the Africa Union and the World Health Organization. The World Health Organization Afro region is an ECHO hub, and the Africa Union has also partnered with us. And we want to expand our partnership with you. Our dream is to help all more than 1 billion people in Africa. And we need your partnership to achieve this goal. And thank you, Chris, for the opportunity to speak at this meeting. And I'm very grateful to you and your colleagues for your leadership in expanding ECHO in Africa.
Thank you, Sanjeev, so much. And I look forward to hosting you personally in Africa, in South Africa. We had a plan last week. Unfortunately, we have had to postpone it. So I look forward to 2022 having you here so that we can share many of our initiatives with you personally. Thank you so much. I'd like now to ask Ibrahim Ayaki, former Prime Minister of Niger and also the CEO of NEPAD, to say a few words. He's busy boarding a plane and has a recorded message for us.
I would just like to say a few words as an introduction to your webinar. We know that the African continent is recognizing a rising number of deaths from viral hepatitis B, and see currently 71 million people on the continent are affected by the virus. And viral hepatitis is a highly endemic public health problem in our continent, comparable to other major infectious diseases such as HIV, tuberculosis, and malaria. We also know the challenges that we are facing in responding to the elimination of hepatitis. And these challenges have to do with inadequate resources, weak health systems, very high cost of diagnosis, test, and treatment, and overall lack of awareness about the disease. If you combine to this a limited capacity to gather data, you have a situation which is quite problematic. And let's just think about the fact that only 18 African countries have formulated national hepatitis strategic plans. And of these countries, only 3 countries have plans which have been effectively funded. So during the third ordinary session of a specialized technical committee on health, population, and drug control, which was held in August 2019 in Cairo, Egypt, African ministers of health endorsed what they call the Cairo Declaration on viral hepatitis in Africa. And in this declaration, the African Union Commission, Africa CDC, the African Union Development Agency, AUDA-NEDPAD, which I am the CEO, and the World Health Organization, as well as development partners, called upon to develop capacity of member states, define priorities for response and innovation, and facilitate operational research on hepatitis. It is against this background, but I would like to express my sincere gratitude to the GHASSA for its commitment to work with the AU institutions in order to contribute to the implementation of the Cairo Declaration on hepatitis and other related disease. And by focusing fundamentally on 4 strategic areas. 1, capacity building of our member states. 2, innovation and operational research. 3, South-South collaboration. And 4, partnership. And what we are discussing today is fundamentally all these issues, and particularly the question of partnerships. The meeting of this afternoon is very important because it provides an opportunity for the GHASSA community to share experiences with staff drawn from AU institutions, especially AUDA-NEDPAD and DUC. So it is my hope, my sincere hope, that these discussions become fruitful and we move towards implementation. Thank you very much.
Thank you very much, Dr. Miyake. Now, with your permission, allow me to hand over to Mark Sonderop, who will chair the rest of the meeting. I'm just recovering from an illness, and I doubt that my voice will hold out. So thank you very much, and over to Mark Sonderop.
Thank you very much, Professor Cassanides. Chris, thank you. I'm Mark Sonderop. It's an absolute delight to host this extraordinary GECO meeting this afternoon. We have literally the father of Project ECHO with us this afternoon, Sanjeev Arora. You've met him. Sanjeev, you're most welcome. I think being involved in ECHO, like with Wendy, over the last 2-3 years, one defines your life pre-ECHO and post-ECHO. And we certainly are living in the post-ECHO life, which is a joy every meeting we have. And I've said on many occasions, Project ECHO is not a noun, it is a verb. You either do it, but you don't just speak it. Also to Dr. Miyake, thank you so much for those words of encouragement. And to everyone attending this afternoon, you're most welcome. And we have some esteemed guests on the meeting this afternoon. And in African spirit, I'd like to say all protocol observed. Just before we continue, we've mentioned the role of GHASSA in setting up the actual GECO meeting. I think it would be remiss of me not to note some founding members of GHASSA on the call this afternoon. And if I miss anybody, my apologies in advance, but we have Mary Afiene from Kumasi in Ghana on the call, as well as Betty Musau from Nairobi. These are all founding members of GHASSA, and we welcome you. We have a short number of brief talks this afternoon from several of my colleagues. We have a virtual brains trust, and we are going to have brief, short, sharp pearls of extreme wisdom, focusing on a range of GI and liver issues this afternoon. I'm just going to briefly introduce them and then hand over for them to roll through their talks, and we'll take some discussions and questions at the end. First up this afternoon, speaking on endoscopy, is going to be Sandy Thompson. Professor Thompson is the recent past retired head of the Division of Gastroenterology at the University of Cape Town Groote Schuur Hospital. Professor Thompson is a surgical gastroenterologist. On IBD, we have my good friend and colleague, Professor Jill Watermeyer. Jill is an associate professor of medicine and is in the Division of Gastroenterology at UCT Groote Schuur. And Jill is a virtual doyen on IBD for those who well know her. Following that, focusing on a very important issue of viral hepatitis, is my senior colleague, Professor Wendy Spearman. Many of you know her. She's the head of the Division of Hepatology at UCT Groote Schuur, as well as the head of the liver clinic and liver transplant clinic. Following her is my colleague, Professor Ed Jonas. Professor Jonas is professor of surgery at UCT Groote Schuur and head of the hepatobiliary unit in the Division of Surgical Gastroenterology. We're then moving on to Professor Vernon Lowe. He's professor of medicine and head of the Division of Hematology in the Department of Medicine at UCT Groote Schuur. And we'll be finishing off on GI hepatology training issues from, again, my good friend and colleague, Professor Mashiko Setchedi. Mashiko is professor of medicine and head of the current head of the Division of Gastroenterology at UCT and Groote Schuur Hospital. So without wasting any more time, I'd like to ask Sandy to step up and for my colleagues to roll in after that. Sandy, the floor is yours.
Thank you very much, Mark, for that introduction. I am a surgical gastroenterologist, but also a medical gastroenterologist by dint of necessity, because I think both divisions have such a degree of overlap. But I would first like to thank all the African Union Development Agency, New Partners for Africa development personnel. Again, it's no wonder that that's used as an acronym, but just like ECHO, it heralds what we really are up to in terms of developing partnerships. And it's my pleasure to try and present to this. And I would again like to thank Dr. Mayaki and Chris for brokering this through their connections, and for Sanjeev as the founding father of enhancing community health outcomes. Again, the acronym doesn't really give worth to the actual concept, and I think it's worthy of the full title. I'm sort of as being zoomed into all these platforms in various guises and through different organizations that I've been involved with. And it is on this platform today that we're using for these discussions. And I really do hope that it will be a launchpad for a partnership in relationship to healthcare in the field of gastroenterology, conceived in Africa for Africans, not delivered to us from outside the continent. My task is to put our endoscopy activities into perspective. I retired from the chair of gastroenterology, as you've heard, 3 years ago, having built up over many years an expertise in the performance and training of endoscopic procedures. In common parlance, these would be known to those non-medical participants in today's session as gastroscopy and colonoscopy. They are the bedrock of the practice of modern gastroenterology and essential, not luxuries, in the management of these diseases. You perhaps also have heard of ERCP, which is a biliary endoscopic radiological procedure, which again is, to be honest, a floundering procedure in our environment. I've done this by implementing in a hands-on way education, including training the trainers and training of both diagnostic and therapeutic endoscopy in South Africa and Sub-Saharan Africa. This is through a variety of organizations and industry partners, notably the World Gastroenterology Organization, the WGO, and its African Regional Association, AMAJ, currently with an Egyptian president, and of course the Gastro Foundation and industry partners. Of course, endoscopy on the African continent must be seen in the context of gastroenterology and liver disease, and that it is essential to diagnose and treat these diseases that are relevant, and what you'll hear from other experts, specific diseases in their fields that are relevant in the African context. In my field, these are carcinoma of the esophagus and the colon, which are specifically relevant in Africa, one as a established disease with a terrible track record, and the other an emerging disease, which again, we cannot ignore in Africa. We do so at our peril. In this guise, I visited Nigeria, Ghana, Namibia, Tanzania, Ethiopia, Egypt, and Sudan in a variety of educational contexts, particularly since retirement and particularly in the pre-COVID era. So I have a familiarity, which I think brings a sort of unique context to my ability to function in the African arena. I know and have visited what things are like here. And from these visits, I've been struck by the lack of resources to practice even routine bread and butter diagnostic procedures that I've mentioned before, gastroscopy and colonoscopy. Far less more sophisticated interventional procedures such as I've alluded to with ERCP or endoscopic ultrasound, both of which are rudimentary to endoscopy units in high-income countries. These resources are generally set up in a limited fashion in the private sector in most sub-Saharan countries and African countries other than those on the Mediterranean coast, Nigeria and South Africa. And there's no doubt that the private sector in these countries is far advanced of the state sector. Unfortunately, it is much smaller and deals with much less volume of disease. And so the greatest need for resources to practice endoscopy is actually sitting with the hospitals and institutions which don't have the equipment or the expertise. This is not unique to in all the countries around South Africa. There are problems with delivery of gastroenterology and endoscopy in particular. And I'd just like to illustrate this because often people consider South Africa to be a very well-off nation in the African context. And perhaps we are better off than many other countries in sub-Saharan Africa. But we are by no means on a par with what the high-income countries can deliver. And I would just like to put this in perspective by sharing some information that I have, that in the private sector, which is about 10 million in our country of the 60 million of the population, they perform per capita 10% more colonoscopies than they do in the whole of the UK, where they have both symptomatic and screening colonoscopy performed. In the public sector, we perform 1/10 per capita of that. So you can see the differential in terms of provision between the private and the state sectors. And again, this is an issue that needs to be addressed, in my view, by health policy. And this is why this meeting is so unbelievably appropriate in terms of trying to bring this on the agenda. Because without endoscopy, the diseases that the others are going to speak about are also not manageable. In terms of manpower, I'd just like to say a few words. In South Africa, we have 100 gastroenterologists. In our neighbours, Namibia has 2, Botswana none, Zimbabwe has 6, 4 of whom have trained in South Africa. Mozambique have 6, 4 of whom trained in Cuba. And most of the others, at the most, have 50 and probably less than 20 in most of the other East Coast sub-Saharan countries. Nigeria probably has the most gastroenterologists on the continent below the desert. Having dealt with the resources, I would just like to illustrate how we've been running our meeting over the past 15 months. And I will show you the advert for the last meeting, just to illustrate what we get up to in this meeting. And then I will conclude, say a few words about that and conclude. So if you could, you can see in front of you our last meeting. At this meeting, this is a surgeon who I came in contact with because he's a member of the African Consortium for the Management of Carcinoma of the Esophagus. He's a remarkable young man, a surgeon, and over 80% of endoscopy is done by surgeons in Africa, primarily because the only other alternative is surgery, and the physicians are too busy with infectious diseases to develop expertise in endoscopy, something that definitely needs to change if we are to build capacity. Again, he has a unique experience, probably the largest experience of a single hospital, a district hospital in Kenya. So this is just one of the many GI and G echo endoscopy meetings that we've held over the past 18 months. All of them we felt have been relevant to practice in sub-Saharan Africa. Unfortunately, these meetings, so they are fantastic, they do not allow us to do hands-on teaching in endoscopy. And we are very much thirsting to get back into activity post-COVID so that we can do some hands-on teaching, which again is really necessary if you're going to develop a skilled, trained individuals in endoscopic procedures that will spare a lot of individuals unnecessary surgery. So I would like to conclude just by saying that GECCO is a vehicle to continue the support for training and to maintain relationships past and present. It is a vehicle and it has a specific role in the training of endoscopy. However, hands-on training cannot be replaced. And I think it's good to put this on the African Union map with a view to see how we can influence policy to increase resources for the diagnosis and management of gastrointestinal disease related to the practice of endoscopy. With that, I would like to hand over to the next speaker, and I think that is Jill Watermere. Jill.
Jill, just please unmute.
Oh, can you hear me now?
Yes.
We can.
Okay. So I'm just going to go back. All right, thanks very much for allowing me to speak today, and it's my great pleasure to be part of this initiative. So I'd just like to also extend my thanks to everybody who's allowed this to be possible. So I'm going to just talk a little about IBD gecko and inflammatory bowel disease, which is my field of interest. So the term inflammatory bowel disease refers by and large to two conditions, Crohn's disease and ulcerative colitis. And these are both inflammatory disorders of the gastrointestinal tract. They are chronic, lifelong illnesses for which there is currently no cure. In general, they are diagnosed in early adulthood, and of course, this is the time when individuals are economically very productive. So as you can imagine, it has a major financial burden for individuals affected with this disease. Sorry, my slides are not moving on. They seem to have frozen. There we go. All right. So, inadequate therapy of these conditions can lead to progressive destructive disease, and this can significantly impact patients' quality of life. Many people require surgery. And other non-communicable diseases, as we know, ischemic heart disease and stroke, which are also on the increase in sub-Saharan Africa, and IBD is certainly no exception. So what we've seen is in the latter half of the 20th century, we saw quite a dramatic increase in inflammatory bowel disease in the Western world. This has subsequently stabilized, but over the last 20 years or so, we have seen a marked increase in inflammatory bowel disease in regions where these conditions were previously uncommon, like South America, Asia, and North America. And more recently, we've actually noticed a trend of increased cases of IBD in sub-Saharan Africa. So why is this happening? Well, we think it's likely to be due to an increased exposure to certain environmental risk factors which are known to predispose to IBD in Western populations. In particular, risk factors that are associated with industrialization. And I think diet is a very important thing here in South Africa because we are having a nutritional transition from the traditional African diet to a Western diet, which is very high in processed foods, animal fats, and food additives, air pollution, improved sanitation, and of course there's widespread health policies which are endorsed by many health organizations around the world at empirically eradicating helminth infections, which are of course a great burden of disease in Africa, but we know that helminths actually protect against inflammatory bowel disease. So this may be another reason why we're starting to see an upswing in these illnesses. So, of course, if IBD numbers in sub-Saharan Africa eventually reach the numbers that they are in the West, which is pretty much an epidemic, then what we're going to see is a rather major health burden from these non-communicable diseases. So what are the challenges in managing IBD in sub-Saharan Africa? Well, this is not unique to IBD. We see it with any other non-communicable disease, poverty, strained healthcare services, and of course, the prioritizing of infectious diseases, and rightly so, such as malaria, HIV, and TB. But there are also many challenges that are specific to IBD. So obviously, we all know that most countries in sub-Saharan Africa still have a two-tiered health service. There's still not much uptake of NHI. We have, of course, the public health service funded by the government and private healthcare, which, as Sandy's alluded to, servicing the wealthy and those with well-paying jobs. And of course, very few people can afford this level of care. There's also a heavy reliance on donor funding. So in general, the public health service, and this is in South Africa, we see this as well, characterized by high patient loads, poor staffing, lack of medications and treatment modalities. And this results in a significant out-of-pocket payment, which actually accounts for more than 40% of healthcare expenditure in sub-Saharan Africa. And certainly in countries like Ethiopia, Nigeria, Kenya, and Uganda, 40% of people in the lowest 20% income distribution receive the healthcare from private for-profit providers. Other challenges, of course, are the unaffordability and unavailability of medications, especially drugs that we use in IBD called biologics, which are extremely expensive. And even in South Africa, where we are better resourced, we have quite limited access, particularly in the public sector. And again, high out-of-pocket payments. There are, of course, also poor procurement pipelines. In many parts of sub-Saharan Africa, we see the problem with illegal drugs, problems with transportation, insufficient cold chain storage facilities for medications, and lack of manufacturing capability. What are some of the challenges that are more unique to IBD? Well, the main one is in broader sub-Saharan Africa, outside of South Africa, this perception exists that inflammatory bowel disease is a very rare condition. And as a result, there is quite a large lack of awareness amongst healthcare workers practicing in sub-Saharan Africa. This is compounded by a very high burden of infectious diseases. And this is because the symptoms of IBD, such as diarrhea, resemble infectious diseases. And I think we all know that amoebiasis is endemic in sub-Saharan Africa and often a cause of diarrhea, particularly bloody diarrhea. So what happens is these patients present to their healthcare professionals and go and receive multiple courses of antibiotics until eventually they come to the attention of somebody who's more experienced in this disease process. And invariably, this can delay effective IBD therapy. And in some reports, one from Nigeria, up to 5 years for ulcerative colitis, which is a very unfortunate situation. Now, the diagnosis of IBD requires a combination of clinical, endoscopic, radiological, and histological findings. And at every one of these steps, there are unique challenges. And these are largely due to strained healthcare infrastructure. We all know about the very low numbers of healthcare workers in sub-Saharan African countries, less than 1 doctor per 10,000 population, slightly higher in South Africa, but still far below what is considered acceptable elsewhere in the world. And specialist gastroenterologists are even rarer, and Sandy's already alluded to some of the figures. And certainly there was a study from KwaZulu-Natal in South Africa showing that there was only 0.06 gastroenterologists per 100,000 population in the public sector in that particular area of South Africa. We also have limited endoscopic capacity, and Sandy has already spoken to this, lack of facilities and trained endoscopists. And certainly, as has been experienced in the West, COVID has significantly worsened the endoscopic capacity, as has been reported from a survey of 14 sub-Saharan African countries. Another main problem is the paucity of pathologists. And pathologists are absolutely key in diagnosing inflammatory bowel disease, and there are approximately 1 pathologist per 1 million people in sub-Saharan Africa, very unequally distributed. The vast majority are in South Africa. Some countries in West Africa, like Nigeria and Ghana, do have some pathologists, but there are many countries in the region that have actually not one single qualified pathologist. Another thing that is key in diagnosing IBD, particularly Crohn's disease, is radiology, cross-sectional imaging. And again, this is very limited in many sub-Saharan Africas, particularly the more advanced modalities like MRIs and CT scans. And within countries, there's also quite an uneven spread. And again, the private sector are far better able to access these modalities. So how can these challenges be addressed? Well, essential education and training are absolutely key, given that IBD is on the rise in sub-Saharan Africa, to heighten awareness of the disease, because not every GIT complaint is infectious in origin. And given the limited exposure to IBD care, we need to have forums to educate health workers about the management of IBD. And IBD Gecko is really the perfect platform to empower healthcare providers across sub-Saharan Africa by imparting the knowledge, expertise, and confidence that is required to diagnose and treat patients with IBD successfully. So I am very fortunate to run the IBD part of our Gecko with my friend, colleague Mashiko Setedi, who's going to talk a little bit later. And we're very excited about this. It's provided a wonderful platform, and this is an advert of our last one where we had Yoa Wuku from Ghana, who took us through one of his very complicated cases. So at this point, we're having them monthly, and we are having attendees on average from about 13 to 17 different sub-Saharan African countries. It's still in the early days, but with each session, we are now starting to gain traction, and there's certainly a lot more interaction each time that we go along. So I'm very excited about this, and I'm hoping that in the near future, we're going to see this bear fruit, and we're going to see an increase in the number of cases diagnosed with IBD, and also that our colleagues in sub-Saharan Africa will have an increased confidence in managing IBD in areas where there has been limited exposure. And I think something that Mashiko and I really believe in is one of the core fundamental principles of Project ECHO, which is the democratization of knowledge. And hopefully we have been able to impart some of our expertise to our colleagues in sub-Saharan Africa. And with that, I'd like to hand over to Wendy.
Thanks, John. Can you see my slides?
Yes.
Yes, we can.
Okay.
Your
So
video,
I'm going to be
your video.
Let's just see. Okay.
There we go.
So I'm going to be discussing prevention of mother-to-child transmission of hepatitis B. And this is really important, as we'll see from my talk, that the prevalence of hepatitis B is really established in early childhood. And as we'll see, that the Africa region is not really doing very well in terms of coming to grips with this problem. So as we know now, approximately 296 million individuals are infected with hepatitis B. In sub-Saharan Africa, it's endemic, and it's an estimated the prevalence is 6.1%. And of concern, there's really a lifetime risk of acquiring hepatitis B in sub-Saharan Africa of more than 60%. If we look at the overall figures, it's thought about 60 million are infected with hepatitis B and 2.7 million are HIV co-infected. And if we look at the recent 2019 burden of disease figures published by WHO, nearly 1 million new infections occurred with 80,000 deaths due to acute hepatitis B, but mainly from complications of cirrhosis and liver cancer. And on this background, we need to remember that hepatitis B is entirely vaccine preventable. However, only 11 African countries have implemented the birth dose vaccine. And if we look at our vaccine coverage, it's only 77%. So in terms of the prevalence, 30 of the 47 WHO Afro countries have a surface antigen prevalence greater than 5%. What is really concerning is the number of children in the WHO Afro region who are surface antigen positive, and that is almost 5 million. And you can see we lead the way here in terms of compared to Western Pacific, Southeast Asia, and the other regions. So this is something that's a real problem, because if we don't address that, we are not going to address the problems of long-term cirrhosis and liver cancer. So recognizing that viral hepatitis, we need to have strategies in order to actually achieve the elimination goals. Just looking at the hepatitis B elimination goals, remembering we're now past 2020, so we need to look at 2030. So the aim is to really have 90% full vaccine coverage and 90% of neonates actually being treated and receiving that hepatitis B vaccine. What were the goals in terms of surface antigen prevalence for children under the age of 5? Well, globally, it was set at less than 1% by 2020 and 0.1% by 2030. Our WHO Afro goals were slightly less ambitious, but less than 2% by 2020. And you'll see that we haven't really achieved this as yet. So in order to understand why we have such a high prevalence, we need to understand the transmission. So in terms of perinatal transmission, there's a 70 to 90% risk of chronicity, and HIV co-infection significantly increases the risk. These pregnant women are far more likely to test positive for DNA, have much higher DNA levels, and are more likely to be e-antigen positive. Importantly, horizontal transmission in early childhood under the age of 5 is an important route, particularly remembering that hepatitis B is 100 times more infectious than HIV. So amongst children, scratching, biting, sharing toothbrushes are important routes. And then adults sharing care facilities such as razors, nail clippers, barber clippers. There was quite an important study that came from the Gambian phylogenetic tree study, and they show that hepatitis B transmission occurred within 2/3 of families. So one really needs to identify infected individuals and break cycles of infection. And in reality, identifying a pregnant woman enables one to actually start that cycle of breaking the infection. In early childhood, the risk of chronicity is between 30 to 50%. Unfortunately, we still have adults who were born pre-introduction of the hepatitis B vaccine, it's the EPI, so sexual transmission remains a risk, but their risk of chronicity is less than 5%. And then always to remember the risk of percutaneous transmission. So really in sub-Saharan Africa, we are looking at perinatal transmission and horizontal transmission. In terms of transmission from mother to child, if we look at the e-antigen prevalence in surface antigen positive women, one needs to see that this is actually variable across the different regions, with the highest region being in West Africa, followed by Central Africa, and then Eastern and Southern Africa. Most countries introduced the universal vaccination in the mid-90s, and the EPI schedule was based on 6, 10 to 14 weeks. And this is on the presumption that most individuals with surface antigen positive, e-antigen negative, and therefore had a potential low risk of perinatal transmission. We know that perinatal transmission from e-antigen positive mothers does tend to be lower than in Asia. This might be related to the viral load as well as the genotype. But I think we need to look at this in context to how severe this is compared to HIV transmission. And this was a systemic review and meta-analysis looking at 11 countries and showed if you were e-antigen positive, the pooled risk was 38% without prophylaxis. So this was significantly lower than the 70 to 90 risk from the Asian literature. And the pooled risk if you were e-antigen negative was 5%, so very similar to Asia. But I think one needs to look at this graph. So if you look at hepatitis B neonatal acquired, this is really double that of HIV. And so we're very good about testing for HIV in pregnant women, preventing this neonatal transmission, but really we're lagging very far behind in preventing hepatitis B transmission. So in terms of what were the vaccination recommendations from WHO? So we know in 1991, it was recommended that the universal vaccination was the most effective way to reduce the global burden of hepatitis B. By 2013, this had actually prevented 14 million cases of chronic hepatitis B amongst children under the age of 5, and more than 1 million deaths. In 2015, 47 of the WHO African region countries had actually incorporated the hepatitis B vaccination into the EPI schedule. In 2009, in fact, WHO recommended the birth dose vaccine for all countries, and importantly, antenatal screening if the surface antigen seroprevalence was greater than or equal to 2%. So where are we in terms of these are recent figures from 2019? We show that only 43% of babies born globally were receiving that birth dose within 24 hours. And as I mentioned, only 11 countries have implemented that birth dose vaccine. And unfortunately, although the global coverage for the full 3-dose vaccination is 85%, we are lagging behind at 77%. And why is that important? Very important studies came from Taiwan, which showed if you had incomplete vaccination, this was an important predictor for the development of HCC with a hazard ratio of 2.52 following correction of the maternal surface antigen status. So not only do we need the birth dose vaccine, but we need to fully vaccinate as part of the EPI schedule. So why is it important to prevent this perinatal infection? This review showed if you acquired an early infection at an early age, there's a greater probability of chronic infection, but also worse liver outcomes in terms of HCC and cirrhosis. And a longitudinal study from the Gambia showed that mother-to-child transmission was a risk factor for persistent high viral replication, significant fibrosis, and the development of HCC. So it's all very well to promote this, but we need to show that it has positive outcomes. And the best outcomes really have been shown from Taiwan and China. So in Taiwan introduced universal vaccination in 1984. They had a very aggressive catch-up vaccination program and improved antenatal screening. And you can see they dropped their prevalence from 10% in 1984 right down to 0.5% in 2014 in individuals under the age of 30. And this translated into a 76% decrease in mortality from fulminant liver failure and a 92% decrease in mortality from chronic liver disease. This is further seen in this map. You see the significant drop in mortality due to chronic liver disease and HCC were decreased by greater than 90%. But importantly, the incidence of HCC decreased by greater than 80%. So you can see by really just introducing vaccination, how you can impact on the burden of disease relating to hepatitis B. China, in partnership with Gavi, really showed very similar, very good results. They provided a 3 birth dose vaccine. They upscaled their vaccine schedule. They improved antenatal surface antigen screening. And importantly, they actually utilized village layer healthcare workers to implement the birth dose vaccine. And you can see here, in 1992, we have a seroprevalence very close to 10%. And by 2014, this drops right down to 0.1%. And it's predicted to be less than 0.1% by 2027. But if you look what happens, as you introduce this birth dose vaccine, you see this steep drop in the prevalence of surface antigen. So we really need to be implementing this birth dose vaccine. So what have we achieved globally? That target of less than 1% by 2020 has been achieved globally. Unfortunately, even though our aim was less than 2% in WHO-Afro, we still haven't achieved that with our prevalence rate of 2.53 in children under the age of 5. So we still need to really be working on this. So in terms of screening pregnant women, so early as 2017, it was recommended that we screen for HIV, syphilis, and surface antigen. In 2020, last year, recognizing the fact that we're really not gaining traction in terms of eliminating hepatitis B, the guidelines were changed and tenofovir prophylaxis was recommended to pregnant women who had a high viremic load, more than 200,000, that they should initiate tenofovir from the 28th week until at least birth, but probably to a month thereafter. If you were unable to measure viremia, you could use the e-antigen as a substitute test. And this was really based on a commissioned systemic review meta-analysis, which showed significant prevention of mother-to-child transmission with tenofovir at 300 milligrams daily. So really proving that we really need to embark on this as well. So the guidelines are quite simple for WHO. You test the mother for the pregnant woman for surface antigen. If they're positive, assess whether they're viremic or not. If they're significantly viremic, greater than 200,000, you start the tenofovir prophylaxis. And you then reassess in terms of the mother, does she need ongoing hepatitis B treatment in her own right? And if you're cirrhotic, really, you should be initiating therapy. Importantly, you must follow this with the birth dose vaccine and then complete those 2 to 3 doses of vaccination. And although the HBIG is still recommended and is still in the guideline, in reality, in sub-Saharan Africa, it's not accessible, it's not affordable. So we really need to be looking at bringing in the tenofovir and the birth dose vaccine. So I think what I've shown you, infection rates really reflect our failure of our maternal and child healthcare programs to prevent mother-to-child transmission and early childhood acquisition. We really need to be very active in terms of actually promoting surface antigen screening, identifying highly viremic women, initiating tenofovir in the 3rd trimester. The birth dose vaccine needs to be given within 24 hours of delivery, and then ensure that we complete the EPI schedule of 2 to 3 doses. Modeling studies over and over again have shown this is cost effective. 80% global scale up of the birth dose vaccine plus infant vaccination compared to just scaling up the infant vaccination alone could potentially avert nearly 19 million new infections over 15 years. It's cost effective, and we really need to push Gavi to deliver on their promise to support the initiation and implementation of that birth dose vaccine. But I think what we've seen repeatedly, we need integration. So we need to promote the triple elimination, which has been put forward by WHO, to eliminate HIV, syphilis, and hepatitis B. One needs to actually adopt these simple algorithms, link individuals to care, task shift and task share, involve the community. But ultimately, we need political support to have this implementation. And really, the ECHO platform is the ideal platform to actually implement, educate around these problems of transmission. And with view to that, we've actually incorporated midwives into our monthly viral hepatitis ECHO programs, and they're going to be joining us from tomorrow. So hopefully we'll start improving the education around this and implementation going forward. Thank you very much. So I think next is Ed, who's going to follow on with HCC.
Thank you very much, Wendy. I'm just trying to share here. HCC. So if you can just confirm that I'm in the right big screen
Yes,
mode.
you are. Yes, you are, Ed. Go ahead.
Thank you very much. Yeah, thank you very much for the opportunity to address also a very important topic in the sub-Saharan African context, and tying in nicely with Wendy's talk, and that is the whole issue around liver cancer. So liver cancer, or hepatocellular cancer as we call it, one of the common forms, is the most common primary malignant tumor in the liver. And you can see there the numbers for 2020. Just over 900,000 cases diagnosed worldwide, but 830 deaths due to the disease. So it accounts for 4.7% of all cancers that are diagnosed, but for 8.7% of all cancer deaths. And then importantly, around 80% of the HCCs occur in sub-Saharan Africa and in mostly Southeast Asia. The etiology, so the possible factors that can cause this tumor, Wendy's already mentioned hepatitis B, and together with aflatoxin B and iron overload, those are the three common etiological factors that are often mentioned in the sub-Saharan African context, but also the other possible causes: alcohol overconsumption, a little bit everywhere, but chronic hepatitis C infection, and also the obesity-related liver diseases that in America really has become a big problem, is also affecting us more and more. So you've seen this map already, hepatitis B prevalence. And if you look at the incidence map of hepatitis B, you can see that many of the areas actually match the high prevalence areas of hepatitis B. And that already gives you a clue that we're dealing with a slightly different disease, certainly in sub-Saharan Africa and maybe also in Southeast Asia. There are a couple of different features in terms of HCC in the sub-Saharan African context. It's got a high prevalence in all sub-Saharan African countries. It's the most common cause of cancer-related death in men on the subcontinent, and the first most common cause of cancer-related death in women. And I've already mentioned the very high fatality ratio. It occurs at a younger age. The patients often present with larger tumors than we see anywhere else in the world, and more often with advanced disease and particularly metastatic disease. There are basically two groups of directed treatment modalities. The first three there that I've got, I think it's a red rectangle around it: hepatic resection, liver transplantation, and local ablation, where we burn the tumors. Those are the three treatment methods that are curative intended. And then we've got some palliative intended procedures as well. And the decision of how to treat a patient is based on algorithms. The most common one used the Barcelona criteria, where we divide the disease into 5 stages, so stage 0 and then A to D, where stage 0 is very early disease and stage D is terminal disease. And based on where the patients fall in this algorithm, they will be eligible for curative intended treatment or palliative intended treatment. The prognosis in the countries that have experience and have got centers of excellence for the curative intended treatments are pretty good. If you stay within the Barcelona criteria and your indications are good, you can achieve 70% 5-year survival in all the curative intended procedures, as I show you there. So if you look at Europe and probably other areas with high income countries, probably around 40 to 50% of patients are diagnosed at a stage where curative intended treatment is feasible. And you can see only about 15% of patients that present at a very, what we call a terminal stage. If we look at the situation in sub-Saharan Africa, only 5% of patients currently present with a disease stage where we can treat with curative intent, and 72% of patients will present with terminal disease. This is a very nice study from Lewis Roberts' group that I briefly saw is in the meeting today, that gives you an idea of how patients are treated on the subcontinent. And there's not much data on this, but this is one of the manuscripts that give us some data. So of the patients in this study, if you take away the patients from the northern part of Africa, there was 1,315 patients that one could look at from the sub-Saharan African countries, as mentioned there. And you can see there that only 8 patients out of the total of over 1,300, and that's less than 1%, actually were treated with curative intent. So even if 5% of patients could potentially be treatable, we currently really undertreat. And that also is seen in the survival curves, where you can see very good survival curves. And Wendy has mentioned the advances that they've made in Taiwan, where things really look good. And if you look at the African curve there, we've got in most countries still a median survival of about 3 months. So where do we go from here? As Wendy has pointed out, HCC in sub-Saharan Africa is an infective disease. It's really an infection, and it can be prevented the tumors can be prevented by the treatment for any other infections. You prevent the infection or you treat the infection. Primary prevention in the form of vaccination really is the key, and I'm not going to say much more about that. But there's also secondary prevention, where patients that are at high risk for tumors are screened and then surveyed. And in the sub-Saharan African context, that would be patients, one of the categories would be patients with chronic hepatitis B infection. And hopefully we can detect more patients at an earlier stage where we can offer them curative intended treatment. Here's a problem with resources in sub-Saharan Africa. We did a quick survey about 4 or 5 years ago on treatment facilities in the countries that I mentioned there, 13 tertiary centers that we had contact with. And you can see there at that stage the treatment possibilities. So only about half of these facilities could offer a liver resection, about a quarter of them local ablation, and at that stage none of the centers could offer transplantation. So where do we go from here? We certainly have to prevent this disease, as I've mentioned, but we also have to treat patients that present with it. We desperately need surveillance and screening and surveillance to detect patients at an earlier stage. And then what I often call a perverse sort of association. You can see here the order of HCC prevalence in Africa: Western Africa, Central Africa, Eastern Africa, and then Southern Africa, almost exactly meet the countries or the regions in the world with the highest rates of unmet surgical needs. So really these patients, most of them are in areas where the infrastructure to treat at this stage is not in place. Just our meetings, we run at the moment once a month an HCC meeting, often in the format of a multidisciplinary meeting where colleagues from other countries in Africa can submit cases. We review them and then we have discussions around them. And on the right there, just next week's meeting, that's again on HCC, we will address the issue of post-operative liver failure, a big problem in specifically patients with hepatocellular cancer. Thank you very much. And I think the next presenter will be Professor Vernon Lowe, that's going to talk to us on patient blood management.
Thank you, Vernon, all yours.
Good afternoon, everybody. And again, thank you very much for the very kind invitation to speak at this meeting. It's really a great privilege and honor. I'm going to focus and just give a snapshot of the problem of iron deficiency anemia in Africa, in particular in pregnancy, sort of contextualizing that in the world setting and why this is really important to all of us. And you'll see today, even if you treat patients with pregnant patients or not, this might even be relevant to you personally. So anemia in general affects about 2 billion individuals worldwide. And of that 2 billion, iron deficiency anemia makes up 1.24 billion, which is almost, I think, exactly the population of Africa. So that's the size of the population around the world with iron deficiency anemia. Another 2 billion have iron deficiency but are not yet anemic. If you look at the areas most affected, similar to what we've heard in these other studies, you can see that anemia is by far most prevalent in the sub-Saharan African region on the far right here, with up to 60,000 per 100,000 population affected. That's like 60% of the population affected with some form of anemia in many regions of sub-Saharan Africa. And if you look at the causes of anemia, iron deficiency makes up more than 50% of the total. In addition, we know that the burden of anemia is 4 times higher in the developing countries compared to the developed countries. And those most affected are children under 5 and pregnant women. Now, if we zoom in on pregnant women, fertile, non-pregnant women, specifically, you'll find that 40% of them overall are iron deficient. So they are at risk of being iron deficient in pregnancy. If we focus on pregnant women specifically, between 35 and 80% of women are already anemic in the Africa, Asia, and Latin American region, compared to 20 to 45% in high-income countries. And 75% of anemic patients in pregnancy are anemic due to iron deficiency. And then you have this other more recently recognized problem that is quite important from a morbidity point of view, and that is that of non-anemic iron deficiency, where patients are iron deficient, they've got complications of iron deficiency, but they're not yet anemic. This is just a figure showing that obstetric hemorrhage is, and this varies from year to year, but it's usually either the second or the third most common cause of preventable maternal deaths in South Africa. And we know, of course, that the access to transfusions is a major problem all around sub-Saharan Africa, and preventing anemia, therefore, is an important aim to prevent any subsequent mortality. But it goes far beyond this. So, of course, the lower the mother's hemoglobin, the higher the maternal morbidity and mortality, because you don't have margin. She's simply closer to the edge. And if she gets to the point of delivery and she's on that edge between decompensating from the anemia, any significant bleeding can just push her over that cliff. But there's other things that people don't often know about, and that includes an increased risk of infection, problems with breastfeeding, increased postnatal depression, bonding between mother and baby, and most people know that the fatigue and forgetfulness is almost taken as par for the course during pregnancy. But there are also effects on the baby. The ones mentioned here are well known: increased risk of fetal death, low birth weight, intrauterine growth restriction, preterm birth, having a lower HB after being born, and as mentioned, poor bonding with the mother. What is less well known, and I think of interest to all of us here today, and I'm just giving you a small snapshot because there's so much to say about this topic. This is a whole lecture on its own, but is that children born of mothers who were iron deficient during pregnancy actually have persistent neurocognitive problems. And here we look at children at the age of 4 to 5. These children were born of mothers that were iron deficient. The children's iron was replaced after birth. But at 4 to 5 years, compared to their peers whose mothers had normal iron, these children had slower perceptual speed, poorer understanding of mathematical concepts, problems with language, emotions. They were more passive, less engaged, and they had decreased self-control on a delayed gratification task. Unfortunately, it didn't stop there. When you follow these children up longer and you get to early adolescence, they still had slower perceptual speed, problems with spatial memory, attention, decreased scores on reading and arithmetic, an increased chance of repeating a grade, needing tutoring, even behavioral issues, risk-taking behavior, and mood, anxiety, depression, social problems, delinquent behavior, and aggression all could be linked back to being born of a mother that was iron deficient. If you move further into young adulthood, there's persistent problems with recognition memory, and they were poor on tests of strategy shifting. When we got to adulthood, and now we're looking at these young people at the age of about 25, they were more likely to be single. A larger proportion did not complete high school nor were pursuing further training and education. They had increased feelings of detachment, poorer ratings of emotional health, and there was an increased risk of being on the schizophrenia spectrum if there was low second trimester iron intake in the pregnant mother, and increased risk of an autism spectrum disorder if low first trimester iron intake. So, as stated by the authors, and you can see this is published in the American Journal of Clinical Nutrition just in this year, by a group who did the largest prospective study on this work, they stated that worryingly these translate into long-term negative effects on mental health, academic performance, career, and earning potential, representing a real challenge for society. I think it's long overdue for all of us to recognize that iron deficiency in pregnancy and in general is a public health problem. I'm often wondering whether some of the problems that Africa has is perhaps just related to something as simple as this, and maybe oversimplification, but it's a completely preventable and treatable problem. Education is, of course, vital. Thanks to the Gastro Foundation and the ECHO meetings, we have a monthly meeting talking about this and similar topics, but we need to have clear implementation plans to prevent and screen for as well as treat iron deficiency. Not sure if anybody here is aware of it, but after dental problems, iron deficiency is the most common health problem in the world, and somehow it has lost the attention of many, if not most, doctors. I thank you very, very much for your attention and for your time.
Mark, I hope it's okay to continue.
Please go ahead, Mashiko.
All right, thank you so much. Good afternoon, colleagues. It's a pleasure to be given the platform to be able to speak about some of the work that we are doing. Today, I'm going to tell you about what we plan to do. So you've heard about the various programs in gastrointestinal diseases and hepatology that are already on offer on the GECO platform. And what we're wanting to do is to introduce another platform specifically for the training of our GI and hepatology
fellows. So I don't know if you're aware that the Gastro Foundation was founded in 2006. And at that stage, Chris's vision was to use the platform for continuous medical education for trained gastroenterologists and hepatologists. And it became clear to him soon thereafter that in fact, what he needed to do was to direct his efforts towards training of fellows. And soon after inauguration of the foundation, the mandate really was to focus on training of fellows rather than the qualified doctors. And so this led to the inaugural SPEAR Fellows postgraduate meeting, which typically happens over a weekend, starting on Friday and ending on Sunday. And it basically involves faculty who deliver a various number of didactic talks, but there's interaction from the fellows. And then we have what we call bases, where we deliver cases and quizzes, etc. And we have interactive learning. And this encourages peer group learning amongst the fellows. It encourages a collaboration because the fellows are coming from all the centers in the country. So this has become a tradition on the Gastro Foundation schedule. And as I say, it happens every year, either in the last week of January or the first week of February. And this meeting has grown in leaps and bounds. As you can see from that first meeting, if you remove faculty and the administrative staff and the secretarial staff, there were about 20 odd fellows at the time. And you can see that when we celebrated the 10th anniversary of the foundation, we had many more faculty, all of us looking a little bit older than 10 years before. We had many more fellows, so this includes medical, surgical, as well as pediatric gastroenterology fellows. And the meeting has simply grown. And as I say, it encourages and enhances relationships between the fellows themselves. And it's really a wonderful time. But then in about 2015, I think Chris then recognized that the achievements of the Gastro Foundation and fellow training in South Africa needed to be extended and expanded northwards into the continent. And this was an important thing, and this is what they started to do. And so there were many meetings that were arranged in the continent, and one of these meetings was a postgraduate course that happened in Lagos, Nigeria in 2015. The following year, there was an offering in Addis Ababa of, again, a postgraduate meeting with a lot of interest from the continent. As has been said by other speakers, we now have people joining from many countries within the continent, which is really wonderful to see the development and the growth of this platform and this method of really democratizing education and improving clinical services for the patients that we serve. So this meeting, which was the 11th postgraduate fellows meeting over the weekend last year, here we were blissfully unaware of the chaos that the COVID pandemic would descend upon us. But we were lucky that we were able to have a meeting last year. But of course, naturally, since then, it hasn't been possible to host many face-to-face meetings. But I think that was the gift that really awoke us to the possibility of using technology to reach people. And one of these meetings was the UEGW Week meeting last year, because of the fact that they were not sponsoring individuals to travel to the meeting. Thanks to Janssen, they were able to sponsor all the fellows at all the centers to attend this meeting virtually. But what we did differently this time was that after the meeting was concluded, we then organized all the fellows in the country from all the centers into 3 groups. And what we wanted them to do was to basically run a meeting where they reviewed the highlights from the UEGW week. And this was facilitated by 3 of us faculty. And it was incredible just watching these youngsters run their own meetings, prepare the presentations, encourage discussions amongst themselves. And in fact, it was here that the idea of using this platform for teaching and training specifically of GIT and hepatology pedagogy was born. At the end of this meeting, we actually discussed the possibility of using the virtual platform specifically for teaching and training. And this we thought would help us to try and standardize teaching across the centers, because indeed certain centers have certain strengths which other centers don't have. And if you can expose the fellows in training to all that is on offer, to various faculty members at different levels of experience, different teaching styles, etc., we thought that this would be a fantastic way to use this platform. And so what we did this year was to run a survey, because given the number of virtual platforms that are out there, particularly for GI, pharma sponsored, both locally and internationally, we thought that before we launch into this, we better find out from the fellows whether this is something that would interest them. And basically this survey was limited to the medical gastroenterologists. And you can see here in question 1 that 2/3 of them felt that there weren't sufficient platforms which were specifically dedicated to their specific training needs. And 100% of the respondents wanted there to be a separated, standalone, dedicated meeting to be used as an educational platform to cover GIT curriculum, to prepare them for exams, and as I said, to attempt to standardize our teaching across all the centers. And you can see that there was a huge interest in having the meetings weekly, if not every fortnightly. So this is what we want to offer. It's still early days. We clearly will use the technology that we've seen works and is already established. We're currently in the planning phase, so these are early days. We've had discussions with the head of divisions across the academic training centers. We've had discussions with some of the GHASSA Foundation trustees and other faculty. And so we need to really refine what it is exactly that we want to do and how we want to go about it. We will have a diverse faculty, including members of the GF trustees, as I say, local and international faculty, and the heads of the divisions, and any other individuals with whom we've been working who are keen on teaching and supporting this venture. We will employ various teaching methods, so didactic talks, case presentations, endoscopic quiz. We'll have access to online material, etc. And really, I think one of the pillars of the Project ECHO is in evaluating utility and outcomes. And I think this will be a very important part of what we do. And there have been a lot of discussions about how we assess the fellows, particularly with the exit exam. And this could be one modality that we use sort of as ongoing assessment of their progress and their knowledge, etc. So I think we could certainly use this to our advantage, and it certainly will boost the current evaluation and assessment tools that we currently have. And we plan to launch this GECO training platform at the next SPEAR meeting, which had to be postponed to September, COVID willing, and then we can have a closer discussion with the fellows with a view to starting at the beginning of the year next year. I'll be happy to take any questions on this and obviously welcome any input. Thank you very much. I appreciate the opportunity.
Thank you, Mashiko, and thank you to our colleagues for that extensive but fantastic tour de force, literally through a number of pertinent issues relating to gastroenterology, hepatology. I'm well aware we passed the hour. Given the extraordinary nature of this particular GECO, I'm going to allow this to go up to the half hour. It's at 6 p.m. South African time. So that leaves us with just a short period of time to take some comments. Before I continue at the start of the meeting, I just wanted to acknowledge some luminaries we have on the meeting today, and they weren't present, or I didn't note them at the time. The one is Professor Fumi Lesi, who is a founder member of GHASSA and a founder member of the Viral Hepatitis Project ECHO for Sub-Saharan Africa, as well as a founder member of GHASSA, Professor Christian Tionchon from Cameroon. We also have, Professor Jonas alluded to it, a very special colleague who's joining from Rochester, Minnesota, the Mayo Clinic, and that's Professor Lewis Roberts. Welcome, Lewis. I wonder if I can just, in literally one line from each of the panelists, if I had to say to you, you have a magic wand, and on the topic you covered today, that tomorrow morning, apart from using one wish to wish away COVID, the second wish you have is for one thing to happen on the topic that you spoke about, just one thing. And I'm cognizant of the time, but if we can all just unmute of the people who spoke, I'd like to go from Sandy downwards. What is the one thing you would want tomorrow morning if you had a wand from the topic you presented? What would you do? Sandy?
What would I do? That's a very good question. I think you need to put endoscopy as a public health resource, that it's absolutely essential for the practice of all aspects of gastroenterology, and that's my wish.
Thank you. Jill?
Okay, so generally what I would wish for my colleagues in Sub-Saharan Africa was better access to endoscopy. As Sandy said, it's the core thing for inflammatory bowel disease. You cannot diagnose it and manage it without access to endoscopy. And then the other thing is I would really wish for our sub-region to have many more pathologists to help us make the diagnosis.
Wendy?
I'm going to go for two things. Screen pregnant women, identify those who are viremic, use that as an ability to screen partners, family members, so that you can break cycles of infection, and then start immediately tomorrow with the birth dose vaccine, regardless of whether a pregnant woman is surface antigen positive or not.
Professor Jonas, Ed?
Yeah, I think first of all, when you also mentioned screening, I think we need dedicated screening. There was a bit of that in the chat as well, dedicated screening for Sub-Saharan Africa, resource sensitive, and that we upgrade our resources at least in all regions to sort of a medium resource scenario for now.
Vernon?
I'd like to see every pregnant woman screened for iron deficiency, not just with a hemoglobin level, but with a ferritin as well.
And Mashika, from a training point of view, what would you do tomorrow across the entire continent?
So there's no question we need more gastroenterologists and hepatologists, but expertly trained people that can deliver the services that patients deserve.
I wonder if I can, from the training perspective and utilizing technologies such as Project Echo, Sanjeev, you still are on the call, I do believe. Can I just ask you for your perspective on utilizing technologies such as Project Echo to extend training in specifically for GI hepatology issues? I think he may have fallen off the call.
Mark, can I make a comment?
Yeah, please go ahead, Wendy.
So I think this opportunity to use ECHO for training is really very important. So we started using the ECHO platform last year to train the fellows going for their FCP exams. And in fact, it made a major difference, particularly during the hard lockdown where most of the international registrars had returned home. It actually enabled them to continue to have weekly training throughout that lockdown. And it made a big difference. So, and we alternated really a fellow giving a didactic lecture with a case presentation. So we would identify a liver case in the wards, a registrar would see it and then present it. And in fact, despite not having full access to the clinical platform, we managed to cover an amazing amount, both in form of didactic lecture and clinical presentation, and teaching how to actually present coherently and the main points. So I think this is going to be a major benefit going forward.
Thank you. I have welcomed her, Professor Fumilesi, or Olufunmilayo Lesi, originally, and I say originally from Nigeria, currently based at the WHO in Geneva. Fumi, I mean, you're at the WHO, obviously you live and eat and breathe policy at the moment. Listening to what you've just heard this afternoon, if you had to, in one brief paragraph, provide some policy framework to the AU, what would you say, bringing together everything you heard? And I'm happy if you focus on particularly viral hepatitis and liver disease issues, because that's obviously where you are centered around the moment. But in general, what would you say? And may I throw another curveball at you? What would you say specifically, because it's been transversal to some of the talks, to African Union countries and member states around the delay in implementing birth dose vaccination for hepatitis B?
Thank you very much, Mark. You know what? I'm going to first use this fabulous opportunity to thank Chris and the Gastro Foundation for their commitment to hepatology and GI and promoting a meaningful South-South collaboration over the past 10 years. That is huge, and we say a big thank you. In terms of AU-NEDPAD and Africa Union, if I had one question, I will ask them to support the implementation of the Cairo Declaration for Viral Hepatitis Elimination in Africa. And it's way beyond birth dose. It is treating hepatitis B and C and preventing liver cancer. It's a package deal. But of course, the tip of the package or the base of the package is the hepatitis B PMTCT. Thank you very much for this opportunity, and over to you.
Thank you very much, Fumi. Thank you for contributing and thank you for being present. I think we are coming up to the hour. It's been a solidly great meeting. Chris, I'm going to hand off to you very shortly. I want to say that I think we should use these core issues been raised by the panelists and speakers, comments made by Fumilesi, perhaps just put together in an absolutely short bulleted point issue around the core issues that we can address simply and efficiently and try and leverage on the support from the AU and the AUDA-NEDPAD. So on that point, I'd like to hand back over to Chris. Thank you to Dr. Aurora for attending and for Dr. Mayaki for his introductory message of support. Chris?
Thanks, Mark, very much. Excellent job there. I wonder if, just as a final comment, Chimwemwe might be able to just give us a quick comment if she's still on.
Yes, I'm still on, and I'm hoping that my colleague Agre might also be still on. He can come in and also give a few remarks. But I think it has been a learning curve for us. We have, I don't know if you can see me. Yes, because I think that's the culture within ECHO. Yeah, so we really appreciate this session. It has been very informative. We've learned quite a lot, but also it just gels together my thinking around the GECO platform, in the sense that I think as Dr. Mayaki said earlier, when we look at the hepatitis declaration and the key issues that are being raised, issues around capacity building, issues around innovation and operational research, South-South collaboration and partnership is quite critical. It has been identified as quite critical within the declaration. And we are excited to get all this information, and we will definitely be putting together our minds, digesting, and see how we can work with you. And I think the important issue that was raised, and I liked that fact that was raised, the fact that let's look at the public sector entities. How do we strengthen the capacity of public sector entities to be able to provide quality services to the population? And I think this is now where the rubber hits the ground when it comes to actual implementation, because it addresses issues around universal health coverage. I mean, we all know a huge proportion or a huge part of our population access services within the public sector. And that's where we need to factor in our efforts. But as the presentations were going on, I was thinking about two things. Firstly, how do we effectively involve governments to ensure that they also take part, they take leadership? I saw at the beginning ministries of health being involved in a number of countries, but I think we need to mobilize more and see how we can bring them on board and support this very important initiative. The other thing that I also thought is that, yeah, there's a community of practice that is already doing something. How do you leverage on the existing efforts and make sure that we push the agenda forward from the AU side? Otherwise, I think we are very excited. We've got a lot of information from this session, and we look forward to engaging further so that we see how we can advance some of the issues that have been raised earlier by a number of experts. Thank you very much to the experts that presented. It was really informative. I don't know if Agri is on the call, maybe he can also provide a few comments if he still is. Thank you.
And finally, Agri, if you'd like to say a few comments.
Chris, I think he may have fallen off the call already.
Well, then, thank you very much. I mean, that remains for me to conclude this very important and extraordinary session of GECO. It's given me a lot of gratification, and I think we have a good working relationship. I'd really like to thank all of you for attending, to all our speakers for contributing, to Project ECHO for their contributions, and we look forward to inviting you back next Wednesday at 4:30 for the next GECO session. Thank you very much, and good night to you all.